Hey everyone, now I will discuss about intraventricular hemorrhage in newborn. To start from etiology, intracranial hemorrhage in preterm infants usually develop spontaneously. Less frequently, it might be caused by trauma or asphyxia, and rarely it occurs from primary hemorrhagic disturbance or congenital cerebrovascular anomaly. Intracranial hemorrhage often involves the ventricles of premature infants delivered spontaneously without apparent trauma. The IVH in premature infants usually not present at birth but might develop during the first week of life. Primary hemorrhagic disturbances and vascular malformations are rare and usually give rise to subarachnoid and intracerebral hemorrhage. In utero hemorrhage associated with maternal idiopathic or more often fetal alloimmune thrombocytopenia may appear as severe cerebral hemorrhage or as porencephalic cyst after resolution of fetal cortical hemorrhage. Intracranial bleeding might be associated with DIC, isoimmune thrombocytopenia, or neonatal vitamin K deficiency, especially in infants born to mothers taking anticonvulsant drugs. Regarding epidemiology of IVH, the overall incidence of IVH has decreased over the past decades as a result of improved perinatal care, increased use of antenatal corticosteroids for preterm babies, surfactants to treat RDS, and the prophylactic indomethacins. So due to those three reasons, the incidence of IVH is decreasing overall globally. It continues to be an important cause of morbidity in preterm infants, as approximately 30% of premature infants less than 1.5 kg have IVH. The risk is inversely related to gestational age and the birth weight. For example, 7% of infants with birth weight between 1 to 1.5 kg have severe IVH, defined by stage 3 and stage 4 IVH. 40% of infants weighing 0.75 kg to 1 kg and 24% of infants less than 0.75 kg have IVH. In 3% of infants less than 1 kg, periventricular leukomalacia develops. When we see the pathogenesis of IVH, the major neuropathologic lesions associated with very low birth weight infants are IVH and the periventricular leukomalacia. IVH in premature infants occurs in the gelatinous subependymal germinal matrix. This periventricular area is the site of origin for embryonal neurons and the fetal glial cells, which migrate outward to the cortex. Immature blood vessels in these highly vascular regions of the developing brain, combined with poor tissue vascular support, predispose premature infants to the hemorrhage. The germinal matrix involves as the infant approaches full-term gestation, and the tissue's vascular integrity improves. Therefore, IVH is much less common in term infants. Periventricular hemorrhagic infarction, previously known as grade 4 IVH, often develops after a large IVH because of venous congestion. When we see predisposing factor for IVH, those includes prematurity, respiratory distress syndrome or hyaline membrane disease, hypoxic ischemic injury, exaggerated fluctuations in cerebral blood flow, such as hypotensive injury, hypervolemia, hypertension, reperfusion injury of damaged vessels, reduced vascular integrity, increased venous pressure from either pneumothorax, venous thrombosis, and the like, and thrombocytopenia. Understanding of the pathogenesis of PVL is evolving, and it appears to involve both intrauterine and postnatal events. A complex interaction exists between the development of cerebral vasculature and the regulation of cerebral blood flow, both of which depends on gestational age. Disturbances in the oligodendrocyte precursors required for myelination and the maternal fetal infection and inflammation. Postnatal hypoxia or hypotension, necrotizing enterocolytes with its resultant inflammation and severe neonatal infection may all result in white matter injury. PVL is characterized by focal necrotic lesions in the periventricular white matter and more diffuse white matter damage. Destructive focal necrotic lesions resulting from massive cell death are less common nowadays. Instead, diffuse injury leading to abnormal maturation of neurons and the glial is more frequently seen. The risk for PVL increases in infants with severe IVH or ventriculomegaly. Infants with periventricular leukomalacia are at highest risk for cerebral palsy because of injury to the corticospinal tract that descends through the periventricular white matter. Regarding clinical manifestation of IVH, most infants with IVH, including some with moderate to severe hemorrhage, have no initial clinical signs, so they are having silent IVH. Some premature infants in whom severe IVH develops might have acute deterioration on the second or third day of life, which is catastrophic presentation. Hypotension, apnea, pallor, stupor or coma, seizure, decreased muscle tone, metabolic acidosis, shock, decreased hematocrit, or failure of hematocrit to increase after transfusion might be the first clinical indication. A saltatory progression may evolve over several hours to days and manifests as intermittent or progressive alterations of levels of consciousness, abnormalities of tone and movement, respiratory signs, and eventually other features of the acute catastrophic IVH. Rarely, IVH may manifest at birth or even prenatally, and 50% of cases are diagnosed within the first day of life if it occurs prenatally, and up to 75% within the first 3 days of life. A small percentage of infants have late hemorrhage between day 40 and 30 after second week of life, and IVH as a primary event is rare after the first month of life. Periventricular leukomalacia is usually clinically asymptomatic until the neurologic sequel of white matter damage becomes apparent in later infancy as spastic and or motor deficits. PVL might be present at birth, but usually occurs later when the echodense phase is seen on ultrasound around 3 to 10 days of life, which is followed by echolucent or cystic phase around 2 to 3 weeks of life. The severity of hemorrhage is defined by the location and the degree of bleeding and the ventricular dilation on cranial imaging. In grade 1 hemorrhage, bleeding is isolated to the subependymal area, whereas in grade 2 hemorrhage, there is bleeding within the ventricle without evidence of ventricular dilation. Grade 3 hemorrhage is IVH with ventricular dilation, and grade 4 hemorrhage is intraventricular and parenchymal hemorrhage. Another grading system describes 3 levels of increasing severity of IVH, which is detected on transfontanel ultrasound. In grade 1, bleeding is confined to the germinal matrix subependymal region, or less than 10% of the ventricle is occupied by blood. This is responsible for approximately 35% of IVH cases. Whereas grade 2 is defined as intraventricular bleeding with 10 to 50% filling of the ventricle, which is the most common one. It is responsible for approximately 40% of IVH cases, and in grade 3, greater than 50% of the ventricle is involved with dilated ventricles. This one is a severe one. Ventriculomegaly is defined as mild if it is between 0.5 to 1 cm dilatation, whereas moderate if it is between 1 to 1.5 cm dilatation, and severe if it is greater than 1.5 cm dilation. When we see the diagnosis of IVH, intracranial hemorrhage is suspected on the basis of history, clinical manifestation, and the knowledge of the birth weight specific risks for IVH. Associated clinical signs of IVH are typically non-specific or absent. Therefore, it is recommended that premature infants less than 30 weeks of gestation evaluated with routine cranial ultrasound through the anterior fontanel to screen for IVH, because most of them are non-specific or asymptomatic. Infants less than 1 kg are at highest risk and should undergo cranial ultrasound within the first 3 to 7 days of age, when approximately 75% of lesions were detectable. Ultrasound is the preferred imaging technique for screening because it is non-invasive, portable, reproducible, and sensitive and specific for detection of IVH. All at-risk infants should undergo follow-up ultrasound at 36 to 14 weeks post-menstrual age to evaluate adequately for PVL, as cystic changes related to perinatal injury might not be visible for up to 1 month. Ultrasound also detects the pre-cystic and cystic symmetrical lesion of PVL and the asymmetric intraparenchymal echogenic lesions of cortical hemorrhagic infarction. Cranial ultrasound may be useful in monitoring delayed development of cortical atrophy, porencephaly, and the severity, progression, and regression of post-hemorrhagic hydrocephalus. Approximately 3 to 5% of very low birth weight infants develop post-hemorrhagic hydrocephalus. If the initial ultrasound findings are abnormal, additional interval ultrasound studies are indicated to monitor for the development of hydrocephalus and potential need for ventriculoperitoneal shunt insertion. MRI is more sensitive tool for evaluation of white matter abnormalities and cerebral injury, and might be more predictive of adverse long-term outcome. When we see the prognosis of IVH, the degree of IVH and the presence of periventricular leukomalacia are strongly linked to survival and neurodevelopmental impairment. PVL, cystic PVL, and the progressive hydrocephalus requiring shunt insertions are each independently associated with poor prognosis. Currently, the outcome for infants with grade 3 and 4 IVH might be improving, with rates of cerebral palsy and neurodevelopmental impairment closer to 30 to 40% at age 2 years. So previously it is more than this. It is more than 30 to 40% to cause cerebral palsy at age of 2 years, if it is grade 3 and grade 4. So currently, to some extent, there is a decrement in the risk of having cerebral palsy. Only 10 to 50% of low birth weight neonates with IVH develop post-hemorrhagic hydrocephalus, which might initially present without clinical signs, without having any large dead circumference, lethargy, bulging fontanelle, apnea, bradycardia, and the like. In infantis in whom symptomatic hydrocephalus develops, clinical signs might be delayed 2 to 4 weeks despite progressive ventricular distension and the compression and the thinning of the cerebral cortex. Many infantis with post-hemorrhagic hydrocephalus have spontaneous regression. Only 3 to 5% of very low birth weight infantis with post-hemorrhagic hydrocephalus ultimately require shunt insertion. Those infantis who require shunt insertion for post-hemorrhagic hydrocephalus have lower cognitive and psychomotor performance at 18 to 22 months of life. Regarding the prevention of IVH, improved perinatal care is imperative to minimize traumatic brain injury and decrease the risk of preterm delivery. The incidence of traumatic intracranial hemorrhage might be reduced by judicious management of cephalopelvic disproportionation and operative delivery like forceps and vacuum use. Fetal or neonatal hemorrhage caused by maternal ITP or alloimmune thrombocytopenia might be reduced by maternal treatment with corticosteroids, IVIG, fetal platelet transfusion, or cesarean delivery. To prevent IVH also, meticulous care of the low birth weight infant's respiratory status and fluid electrolyte management with avoidance of acidosis, hypocarbia, hypoxia, hypotension, wide fluctuations in neonatal blood pressure or partial pressure of carbon dioxide, because secondarily fluctuation in cerebral perfusion pressure can occur, and pneumothorax are important factors that might affect the risk for development of IVH and PVL. A single course of antenatal corticosteroid is recommended in pregnancies between 24 to 37 weeks of gestation that are at risk for preterm delivery. Antenatal steroids decrease the risk of days, grade 3 and grade 4 IVH and PVL in the neonate. The prophylactic administration of low-dose indomethacin, around 0.1 mg per kg per day for 3 days to very low birth weight preterm infants, reduce the incidence of severe IVH. Regarding treatment of IVH, once it happens, treatment is most of the time supportive with seizure treatment with anticonvulsant drugs. Anemia and coagulopathy requires transfusion with packed RVH or FFP. Shock and acidosis are treated with fluid resuscitation. And insertion of ventriculoperitoneal shunt is preferred method to treat progressive and asymptomatic post-hemorrhagic hydrocephalus. A ventriculosubgaleal shunt is inserted from the ventricle into surgically created subgaleal pocket, which provides a closed system for constant ventricular decompression without these additional risk factors by a gradient. This is what I have for you regarding IVH in newborns. Thank you for your attention.